Hey everyone, welcome back to the Deep Dive. Today we're tackling a topic that might seem small, but honestly has a huge impact on daily life.
Mhm.
Your temporomandibular joint.
Mhm.
You know, that hinge connecting your jaw to your skull, the sort of unsung hero that lets you talk, chew, yawn, all that stuff. We're diving deep into the fascinating world of TMJ mobility, specifically when it's either too restricted or maybe too loose.
Yeah, it truly is a marvel of the human body, and when something goes wrong with its movement, it can drastically affect everything from eating to just speaking clearly.
Exactly.
Our sources today give us a really comprehensive look at both hypomobility, that's, limited jaw movement, and hypermobility, which is the excessive movement side of things. We're basically aiming to cut through the complex medical terminology and reveal the real-world implications.
Right. Our mission is to give you a clear, kind of actionable understanding of what causes these jaw issues, how they're diagnosed, and, well, the full spectrum of modern treatments available now. Think of it as a clear roadmap to truly being well-informed about your jaw. So as we look at this rich stack of information, what's one of the first crucial distinctions that jumps out at you when we talk about TMJ mobility?
Well, what immediately strikes me is just how diverse the underlying causes can be for TMJ problems. It's far beyond just a simple clicky jaw.
Yeah.
Our sources really emphasize that understanding why the jaw isn't moving correctly is, well, it's absolutely paramount for any effective treatment. We're going to explore everything from sudden trauma to long-term systemic diseases and even issues that can sometimes arise from other medical procedures.
Okay, all right, let's start with maybe the more restrictive end of the spectrum, when
Yeah.
your jaw just won't move enough. This hypomobility. It sounds like it could range from just a minor annoyance to, well, a complete inability to open your mouth. What exactly are we talking about here?
In simple terms, yeah, it's a restriction in the jaw's natural range of motion. Our sources pinpoint trauma as the most commonly identified cause, followed pretty closely by infections.
You know,
But the list actually extends to a surprisingly wide array of systemic diseases conditions that affect your whole body. Things like ankylosing spondylitis, rheumatoid arthritis, scleroderma.
like autoimmune stuff.
Exactly. Autoimmune diseases where the body's immune system mistakenly attacks its own tissues, sometimes including the joints, causing inflammation, stiffness, that kind of thing.
Right.
And we even see what are called iatrogenic causes. That's a medical term for issues caused by medical treatment itself.
Oh, okay.
For instance, high-dose radiation to the muscles used for chewing, maybe after cancer treatment, certain brain surgeries like craniotomies, or less commonly, jaw-correcting surgery called orthognathic surgery.
Wow, so it's a whole spectrum of origins, truly. To make sense of all this, doctors must have ways to classify these different types of limited movement, right? Can you help us break those down a bit?
Certainly. Yeah, the sources describe different classification schemes. One common term you might hear is trismus,
Trismus, okay.
which usually refers to a temporary inability to open your mouth fully, often due to muscle spasms. This can happen from an infection, an injury, maybe even certain medications. Imagine your chewing muscles just clenching up so tightly you can't relax them.
Oh, yeah, I've heard of that often with, like, wisdom tooth
Yeah,
extraction.
exactly. That's a common one. Then there's ankylosis, which is much more severe and often a permanent condition. Think of it like a door hinge that has literally rusted solid where parts of the joint actually fuse together.
Wow.
And we classify ankylosis by where it happens. Intra-articular, meaning inside the joint itself, or extra-articular, meaning outside the joint capsule, but still impacting movement. It's also classified by what tissue is involved. Is it bony, fibrous tissue, or maybe a mix of both? And finally, by its extent, is it a complete fusion or just an incomplete one? True ankylosis specifically involves fusion right within the TMJ capsule. Often it's a bony union where the rounded part of your jawbone, the condyle, actually welds itself to the socket in your skull, the glenoid fossa.
Welds itself.
Yeah, and there's even a 3-stage grading system by Topazian that further categorizes complete ankylosis by how much bone has formed, from just the condylar process all the way to another part of the jawbone called the coronoid process.
Welds itself really puts it into perspective. That sounds incredibly severe. So if true ankylosis is a fusion, what's false ankylosis or pseudoankylosis? Is it less serious or?
That's a great question, and yeah, it's a crucial distinction. False ankylosis or pseudoankylosis. It describes limited jaw mobility that comes from factors outside the actual joint capsule. So the joint itself might be okay structurally, but something surrounding it is restricting the movement. This could be due to scar tissue or fibrosis, maybe after an injury, or a fracture in the cheekbone, the zygomatic arch that physically blocks movement, or even just a persistent muscle spasm.
Gotcha.
If we connect this to the bigger picture, it really highlights that your jaw's movement is this complex interplay of the joint itself, the surrounding muscles, other structures. It's definitely not just about one moving part.
That distinction is key. So what does this all mean for someone actually experiencing it? How would a patient typically present, and what might they feel?
Well, patients with the more severe fibrous or bony ankylosis experience significantly restricted mandibular motion, obviously. But here's a truly critical insight, especially for our listeners. While this is challenging for anyone, its impact on children is profoundly different.
How so?
In growing children, especially if the ankylosis is just on one side, it can actually reshape their face over time. It can lead to noticeable lower facial asymmetry, a shortened jawbone on the affected side, and even secondary effects on how their upper teeth align and the midfacial structures.
Wow.
It really underscores why early diagnosis and intervention are so incredibly vital in pediatric cases. Adults generally, they experience the limited jaw opening and reduced forward movement, but usually without those dramatic growth-related changes we see in kids.
Right.
However, some systemic rheumatologic diseases, like scleroderma, can lead to a loss of the jaw joint structure and maybe a less prominent jaw angle. Sometimes that even causes an anterior open bite where the front teeth just don't meet when the mouth is closed.
That's a stark difference, especially thinking about children's development. So how do doctors get a really clear picture of what's happening inside such a complex joint? What imaging tools are most effective?
Yeah, imaging assessment is absolutely critical here. While basic x-rays can show some bony abnormalities, they often vastly underestimate the true extent of the problem.
Okay.
This is where advanced imaging really comes in. Computed tomography, CT scans, especially with 3D reconstructions, are invaluable. Imagine taking hundreds of x-ray slices and then building this precise three-dimensional model of the jaw.
Yeah.
This defines the full extent of the ankylosis and, crucially, its relationship to vital structures nearby at the skull base. That's just essential for surgical planning.
Makes sense.
MRI, on the other hand, it excels at showing soft tissues, things like the little disc, the meniscus position, or fibrous ankylosis. But when it's a bony problem, CT is definitely the superior choice for clarity.
That makes perfect sense. Using the right tool for the right job. You mentioned trauma as a major cause earlier. What kind of trauma are we talking about, and how does that lead to these severe restrictions?
Trauma is indeed the most common cause of both bony and fibrous ankylosis. Often it starts with bleeding inside the joint capsule itself and intraarticular hematoma.
Okay. That blood then scars, and remarkably, can sometimes lead to the formation of actual new bone within the joint. In children, as we mentioned, a fracture of that condylar process can severely impact facial growth, affecting speech, chewing, oral hygiene, and in really severe cases, even breathing. It's pretty sobering to realize that over 40% of pediatric facial fractures involve that specific condylero-subcondylar region.
Wow, that high.
Yeah. And another interesting, though less common, traumatic outcome is something called myositis ossificans traumatica, or MOT.
MOT, okay.
This is where, after an injury, soft tissues, particularly muscles, actually start to turn into bone.
Wait, muscle turns into bone?
Effectively, yeah. Imagine your muscle effectively calcifying, stiffening up almost like bone. This is diagnosed by seeing these calcifications very clearly on CT scans.
That's a powerful and slightly unsettling image. What about infections or even treatments for other serious conditions like cancer? You mentioned radiation. Right. Post-infectious hypermobility, usually from things like dental infections spreading, ear infections, or mastoiditis. It's thankfully less common now because we have good antibiotics, but it definitely still occurs.
Okay.
Mass lesions, too, both benign and malignant tumors, can physically block jaw movement. And yes, radiation therapy for head and neck cancers is another significant cause. It leads to what's called fibromyositis, basically. The muscles and soft tissues become scarred and stiff from the radiation. Studies actually show a linear dose-related effect. The more radiation those pterygoid chewing muscles receive, the greater the jaw dysfunction tends to be, even at relatively low doses sometimes. But the crucial takeaway here, and it's an important one, is that early aggressive physical therapy, often using mechanical devices like the Therabite system, which helps stretch and open the jaw, has proven very effective in these patients. Early intervention helps a lot.
So we've explored the causes and how doctors diagnose these issues. Now, for the really critical part, how do you fix this? Given the sheer variety of ways hypomobility can show up, I'm assuming treatment is far from a simple kind of cookie-cutter approach.
You're absolutely right. Treatment for hypomobility is anything but simple, and there's definitely no one-size-fits-all solution. The overarching goal is always to restore normal, comfortable jaw motion and hopefully prevent the condition from getting worse.
Right.
We always start by addressing any reversible causes first, things like muscle spasms or active infections. But for true ankylosis where the joint is actually fused, treatment is complex and almost always involves pretty aggressive surgical removal of that ankylosing mass, followed by joint reconstruction.
Okay.
Our sources discuss some historical methods like gap arthroplasty, which aim to just create a new joint space, but, well, that approach has largely been abandoned.
Why was it abandoned if the ideal was to create space? Seems logical.
It sounds good in theory, yeah, but it actually led to very high rates of the fusion just happening again, reankylosis and other complications like misaligned bites. Essentially, the body often just tried to fuse it all back together again.
Ah, okay. So what's considered the more successful, more comprehensive approach today?
The Kaban protocol is highlighted in our sources as a very successful sequential protocol. It involves a much more aggressive resection, meaning removal of the fused bone, extensive dissection of the surrounding muscles that might be scarred down, and often a coronoidectomy that's removing another piece of the jawbone that can sometimes get in the way.
Right.
If needed, a similar procedure might even be done on the opposite side to ensure the patient can achieve a maximal interincisal opening of at least 35 millimeters. That's roughly the width of 3 fingers, kind of the target goal.
That's a very specific target. And how is the joint actually rebuilt after removing so much bone?
Good question. Reconstruction typically involves using a temporalis fascia flap, that's tissue taken from the temple area, and usually a costochondral graft, which is a piece of rib cartilage with bone attached.
From the rib, wow.
Yeah, this rib graft then serves as a new condyle, a new ball for the joint. What's fascinating is that newer modifications sometimes substitute something called distraction osteogenesis for the graft.
Distraction. Osteogenesis.
Yeah, it's a process where a special device is used to slowly and carefully encourage new bone to grow, essentially stretching it into place over time. This can potentially avoid needing a bone graft from another part of the body altogether. Not only does it eliminate the donor site, but it can also allow for immediate jaw mobilization and earlier physical therapy.
That sounds incredibly intricate and quite advanced, honestly. But with such aggressive surgery, there must be potential complications. What are the main risks tied to these procedures?
Absolutely. This raises an important point about the risks. Aggressive bony removal near the ear can sometimes lead to an oral TMJ fistula, which is basically an abnormal tunnel forming between the jaw joint and the ear canal. That could potentially cause hearing impairment.
Oof.
Recurrent ankylosis, the fusion coming back, is always a concern, especially if the initial removal wasn't absolutely complete. Outcomes in pediatric patients, despite really strict protocols, can sometimes be less optimal. Children occasionally don't quite achieve that ideal 35 millimeter opening target, particularly in cases where the condition was present at birth on both sides. There are also risks of peripheral nerve injuries, especially to the delicate branches of the facial nerve controlling facial expressions, and even parotid gland injury, which can affect saliva production.
Right.
And specifically with costochondral grafts, there's the risk of unpredictable growth. Sometimes they can overgrow, leading to a new facial asymmetry later on. That's precisely why aggressive and prolonged physical therapy after the surgery is just as critical as the surgery itself. It's a long road.
That really underscores the complexity.
Yep.
Okay, let's flip the coin now and talk about the opposite problem. Hypermobility. If hypomobility is a jaw that can't open enough, hypermobility must be one that opens too much or maybe gets stuck open. Is that about right?
That's the perfect way to think about it, yeah. Hypermobility, or excessive jaw movement, is generally categorized into 2 main types. First, there's subluxation.
Subluxation.
Imagine your jaw joint coming slightly out of its socket, but it's a partial dislocation that can self-reduce, meaning the condyle momentarily passes too far forward past that bony bump called the articular eminence, but then the patient can easily close their mouth again. It often happens with wide-opening actions like a big yawn or sometimes during prolonged dental treatment.
So it kind of pops out, but then it pops back in on its own.
Okay.
And dislocation.
Dislocation, in contrast, is more serious. This is a long-lasting inability to close the mouth. The condyle is fully forward, often superior, sort of upwards relative to that articular eminence, and it does not self-reduce. The jaw is truly locked open. And much like hypomobility, the causes are varied. They can include neurologic disorders, connective tissue disorders like Ehlers-Danlos syndrome.
Oh, where people are sort of extra flexible.
Exactly, where the body's connective tissues are unusually flexible, leading to loose joints pretty much throughout the body, including the jaw. Certain medications can also contribute, or even trauma that happens when the mouth is wide open.
So if your jaw gets stuck in that dislocated position, locked open, what's the immediate intervention? What do you do?
For an acute dislocation, yeah, prompt reduction is key. Ideally, before the surrounding muscles go into intense spasm, because that makes it much harder to fix.
Right.
This is usually done by applying downward pressure on the back teeth, on the mandible, then gently guiding it backward and upward to reposition the condyle back into its socket. Often, it can be done without anesthesia, right there in the clinic or ER. But muscle relaxants might be needed for more prolonged or resistant cases.
Mhm.
After reduction, immobilizing the jaw for a few days, maybe just with a soft bandage wrap, helps the tissues heal and reduces the chance of it immediately happening again.
And what if it keeps happening, or it becomes a chronic issue? What are the sort of long-term solutions for chronic hypermobility?
Right, chronic dislocation requires a more interventional approach because simply reducing it repeatedly isn't really a lasting solution. Historically, some doctors tried injecting sclerosing agents into the joint.
Sclerosing agent.
Yeah, substances that cause scar tissue to form, theoretically tightening things up, but these were largely abandoned due to complications and unpredictable results.
Mhm.
Surgical treatments today generally aim to limit how far the mandible can move forward. Plication procedures, for example, involve surgically tightening the joint capsule itself or sometimes fastening the condyle to a fixed structure nearby to restrict its forward movement. Another approach is to create a physical, mechanical impediment to translation. Imagine trying to deepen the glenoid fossa of the socket or building up a sort of bony barrier to block the condyle from sliding too far forward. This can sometimes involve using bone or cartilage grafts. Interestingly, a procedure developed way back in 1943 by Leclerc and Gerald, which involves surgically moving the zygomatic arch cheekbone slightly downward, has actually shown excellent long-term success in preventing dislocation.
Moving the cheekbone down. I've also heard of something called an eminectomy. Is that another surgical option for this?
It is, yeah. The eminectomy procedure, introduced back in 1951, takes a kind of different approach. Instead of trying to block the condyle, it involves removing a portion of that articular tubercle and eminence, essentially, flattening the bony ramp that the condyle normally slides over.
Smoothing it out.
Exactly. The idea is to allow the condyle to move freely forward and back without getting caught or locked. It can be done as an open surgery or arthroscopically, using small incisions and a camera. However, it's not without its concerns. Some patients might actually experience increased hypermobility afterwards or persistent clicking noises in the joint. There are risks like facial nerve injury, and it can also, paradoxically, lead to recurrent dislocation in some cases. Reported failure rates range quite widely, somewhere between 7% and maybe up to 33%.
That's a pretty wide range of potential outcomes.
Yeah.
Are there any less invasive options, maybe particularly if the muscles are playing a big role in the problem?
Absolutely. Yeah, if muscular hyperactivity is thought to be a significant contributing factor, there are definitely less invasive options. Lateral pterygoid myotomy, for instance, is a procedure that surgically weakens one of the main chewing muscles, the lateral pterygoid, to decrease its forward pull on the jaw.
Okay.
But more recently, and becoming increasingly common, is the injection of botulinum toxin type A. Yes, often known as Botox, directly into those lateral pterygoid muscles. It's showing really great promise for chronic recurrent dislocation.
Botox. For your jaw dislocating, how did that work?
Well, it temporarily weakens the muscle, right?
Yeah.
So it reduces its ability to pull the jaw forward too forcefully, thereby preventing it from going past that point of no return and dislocating.
Oh, how long does it last?
It's typically effective for about 2 to 3 months per injection cycle, so it needs repeating. While it's proven to be a very helpful tool for many, it's important to be aware of potential side effects. They're usually temporary and dose-dependent, meaning related to how much is injected.
Like what?
Things like minor changes in salivary consistency, or perhaps temporary weakness in swallowing, speech, or other nearby facial muscles. But the key is that these are usually manageable and resolve as the toxin wears off.
Wow, okay, that was truly a deep dive into the temporomandibular joint. I mean, from trauma and genetics to really complex surgeries and even Botox.
Yeah.
It's abundantly clear that jaw mobility is an incredibly intricate system with many moving parts, literally.
It truly is. This deep dive really emphasizes that understanding the specific causative factors, whether it's, bony fusion, muscle spasm, ligamentous laxity, maybe a shallow joint socket, understanding that why is absolutely imperative for an accurate diagnosis and a truly tailored treatment plan.
Yeah.
And improved imaging techniques, particularly those three-dimensional CT scans we talked about, are just invaluable adjuncts, giving surgeons a really clear picture of the altered anatomy before they even make an incision.
And it's clearly not just about the procedure itself, is it? That ongoing journey of physical therapy and consistent long-term follow-up seems just as crucial for success, especially after something as complex as a jaw reconstruction.
Indeed. Yeah, absolutely. Knowledge is most valuable when it's understood and applied, right? And critical thinking is so essential in this world of information overload. This deep dive into such a vital, yet, like you said, often overlooked joint. It raises an important question, I think, for you, the listener, to consider. How might a better public understanding of these diverse TMJ conditions lead to earlier diagnosis and ultimately significantly improved outcomes? Especially thinking about children whose facial growth can be so profoundly impacted by these issues.
Definitely something to chew on, for sure. Thank you so much for joining us on this deep dive. We really hope you feel more informed and empowered to understand this vital part of your body. Until next time, keep digging for knowledge.